Hey everyone, it's that time again. We are kicking off our legendary Summer Declutter Challenge, and trust me, you do not want to miss this one.
So true. For the entire month of June, we're playing a numbers game that will transform your space. Each day, you'll release exactly as many items as the date on the calendar. So June 1st, just one item. By June 15th, 15 items are heading out the door. And yes, as the month progresses, the challenge gets a bit more challenging.
But here's the magic. You are never doing this alone. Our community has your back every step of the way.
The secret weapon, every Saturday in June, we declutter together in real time. That's right, decluttering body doubling.
These Saturday sessions are pure gold. Ask those burning organizing questions. Humble brag about your wins. We live for those. And connect with fellow declutterers who get it.
By June 30th, you'll have released 465 items and reclaimed your space just in time for summer fun.
To learn more and sign up today, head over to takecontroladhd.com/declutter. That's takecontroladhd.com/declutter. Hello, everybody, and welcome to Taking Control, the ADHD podcast on True Story FM. I'm Pete Wright, and I'm here with Nikki Kinzer.
Hello, everyone. Hello, Pete Wright.
Oh, Nikki, we're continuing our ADHD and the BOD series.
Yes.
That's what it's called now. I think I
BOD.
was called out for using the BOD last week, and now it just stuck. ADHD and the BOD, and today we're talking about hormones, which we've danced through hormones in the last couple of episodes, and today we're going deep. Very excited to do that. We have a very special guest to help us. Before we dig in, head over to takecontroladhd.com to get to know us a little bit better. Listen to the show right there on the website or subscribe to our mailing list, and we will send you an email when the latest episode releases each week. You can connect with us on Blue Sky and Facebook and Instagram and Pinterest at Take Control ADHD. But to really connect with us, jump into the Discord community. It's a super easy way to connect with people just like you. TakeControlADHD.com/Discord will whisk you over to the Discord login page. And you can join us right there, set up a new account if you need to, or use your existing account and suddenly you're in our server. It's like magic. If you're looking for a little more, and let me tell you, I don't know if you've noticed, but I'm now gesturing broadly. The economy is bonkers. And if you love this show, and if you've been listening to the show for a long time, we sure would appreciate it if you would check us out at patreon.com/the ADHD This is listener-supported podcasting. For a few of your bucks each month, they add up to more bucks for us that keep food on the table, shoes on the feet, podcasts, and mics hot. So patreon.com, you get perks, you get extra secret channels in our Discord server once you're a Patreon member. You get extra episodes, you get bonus content, you get all sorts of great things. The entire extra podcast episodes come out for you as a member in your own personal podcast feed over on Patreon. It is incredibly helpful right now more than ever for your support of this show. Incredibly helpful. We cannot stress that enough. So thank you in advance for people who are already supporting us, and for new people considering, water's warm. Jump on in. Let's do it. It's really fun. I promise. Today, we are diving into a topic that is often overlooked, yet deeply, deeply felt. The complex and frustrating intersection of ADHD and hormonal changes. For women with ADHD, shifts in estrogen and other hormones during puberty, pregnancy, perimenopause, and menopause can reshape how ADHD shows up entirely. Today, we want to come to understand these changes and reclaim a sense of control during life's most unpredictable transitions. To help us do that, we welcome Dr. Dara Abraham, a board-certified psychiatrist who brings both clinical insight and lived experience to her work. Through her boutique practice, writing for Attitude Magazine, and advocacy in the mental health space, Dr. Dara has become a guiding voice in helping women understand how ADHD and hormones interact and how to get the support they deserve. Dr. Dara, welcome to the show.
Thank you for having me. Can you hear me okay?
Oh, yeah.
Yes. Okay, good.
Yes.
You're great. All right. Let's dig in. What was it that drew you and your studies to talking about hormones and hormonal changes?
So I've always been interested in ADHD, And, so slowly it just, slowly I got into really loving talking to women about ADHD. And somehow figured out that really women were just being dismissed constantly because they didn't present the typical way as men did. And that was since childhood. They didn't present as hyperactive, really impulsive. Really, it was more of the daydreamer, just like myself. Really, more anxious, sometimes even more high achieving. A lot of times, just really just very, people pleasing and just very different than little boys. But what I also noticed that a lot of times during their cycle, this was not as common for myself, but for many, they really did not, their medications were not as effective. And what I noticed was they were being dismissed again. And so it was this constant feeling like they were crazy. And so really, it was just really learning about the different reasons why. And so I started to notice that it happened right when they would go through puberty, and then again during something called PMS, and then PMS on steroids, and then again during pregnancy, postpartum. And that's not just postpartum depression, but what we call after pregnancy, the postpartum period. And then again during what's called, the perimenopause before someone goes through menopause. And all of this kind of putting it all together, I realized what's going on. And it really is the change in hormones. And then, and so really it was just really kind of my patients trying to figure out what was going on with them and trying to really help them solve the problem, which is what I'm always doing, is really kind of working in that space of what can we do? There's always a solution. And I was just kind of, that's always been really a popular topic. And so I went with what was popular.
And boy, are we so glad that you are here today. This is a topic that is been brought up many, many times with my own clients, with our listeners. It's a popular topic that we just don't talk a lot about. So I have questions. I have thoughts. And it's so interesting when you're talking about the different kind of stages that we are as women and the hormones. I remember being in the hospital right after I gave birth to my first son, and I could not stop crying. And I thought for the first time I understood how hormones can affect you without any control. Like you have no control. I was uncontrollably crying because he came in to the hospital, or came back in from the doctor, and he got clipped, whatever. And he was crying and I was crying and I couldn't stop crying. I mean, the whole thing was a huge mess. And then perimenopause, and now I'm in menopause, and I don't have ADHD. I will just say that I don't have ADHD, and I know what it feels like as a neurotypical to go through all of those things. And then you add ADHD on top of it.
It's bizarre.
Yeah. So I think it'd be helpful, unless Pete, do you want to say something before
I only
get
have,
into?
No. I believe me, I'm ready for this. But I think that it's so funny. An hour ago, but long before we started the show, we had our first question come into the chat room, and usually we save these for after. But I thought it would be a really good sort of table setting to understand where we are as a community around hormones. This was Angela who said, "So, hormones." I kind of picture her crossing her arms and leaning against a wall.
Yeah.
So hormones. I'm told we all have them, us biological organisms, that is. However, as someone who took biology until 19, I found we're only introduced to those that separate us relating to biological sex. But surely there are more that we share as humans. What are some key hormones and their actions that we should be aware of from an ADHD or human perspective? So I present that question as a table setting, recognizing that this is a conversation that for us today affects predominantly women and the hormonal changes that are so huge, but also humans and, dudes too. So that's our foundational argument. And thank you to Angela for getting that on the table. And now I step back like Homer Simpson in a shrub. Let us begin.
Yeah, so that's a great question. And I think it really does point to why males and females do present differently at different times with ADHD, even going back to males presenting younger and, a little bit sooner. Basically, what happens is we can think of, let's back up for a second. Estrogen, there's really three main sex hormones, and those are estrogen, progesterone, and testosterone. And yes, we all have all of them. Even females have testosterone, but we have less than males. And this is biological, and this is excluding, with transgender. I don't want to exclude, but we're going to exclude that for now. Biological females and males. And then males also have some, estrogen, female sex hormones. But if we keep things, as females have more estrogen and progesterone, what happens is it's not during puberty that things change. And so what happens is everything is equal. And then they mostly have the inattentive symptoms. And that's just how it is. And then once they go through puberty is when things start to change. And then they become a little bit more hyperactive and impulsive. And that's when they get a little more chatty. And that's where you see their impulsiveness. And they get a little more, loud, and they talk back to the teacher or their parents, and they become more hormonal. And that's when what happens is their estrogen increases. However, what happens is that the estrogen actually can be helpful for the dopamine. So estrogen is our friend and it helps. But then they have this menstrual period that comes on. And so so even though it helps dopamine, which is our friend for ADHD and attention and concentration, then every month it goes down again. So that fluctuation, it's what causes the ADHD to get worse for females between the ages of 11 and 16. And so that's why you notice that females who need a dose change in their meds between that time, like 12, that's why, as opposed to boys kind of can go on the same dose for years. So really it's, and then testosterone actually has a negative effect on dopamine. So they've always...
amen.
Yeah. But yes, it's just always been, not so helpful. However, the one thing really to be mindful of, and I don't think I don't know how much, there's never that much studies on this, but there's inference, is that these sex hormones, what happens is they become like neurotransmitters, like these neurochemicals, and they can act, we'll kind of, dumb it down. They act like dopamine and serotonin and norepinephrine, or, basically chemicals in the brain the same way. And so they can act just as, similar. And that's why they can make you feel sad postpartum and feel depressed or feel less alert. If they act like serotonin, you feel sad and anxious. If they act like dopamine, or the dopamine goes down, you feel less alert, less able to concentrate, things like that.
Let's talk about hormones and ADHD. How does the addition of ADHD then affect the interaction that our bodies with hormones happens? I mean, you've talked about that a little bit. Let's expand. What I guess more of the question of what do we do in this situation? Because we know it's not good. We know it's not good. We know that our medication gets affected.
Well, number one, we have to make sure that we're, kind of we're aware of it. We know that we're not crazy, we're not crazy. We're not making it up. It's a real thing. Number two, that we have a provider, that is listening to us, that's open to this, even though they may not have learned about it in their training or really known about it, that you're able to maybe advocate for yourself, even if they are not aware of it, that you can go about kind of educating your provider, your prescriber, if you don't feel comfortable, and if you are able to find someone you're able to talk to, or if you can't, because there's a lot of times you can't, coming up with ways to communicate it maybe in a way that your provider prescriber can hear. And also coming up with maybe some non-pharmaco therapy ways to manage, such as coaching and executive skills training, like behavioral management. I know this is a lot of just gibberish, but really, there are ways to help yourself if you really pay attention to your cycle. Not everyone has a regular cycle, or that you're going to be getting pregnant again, really knowing where you are in your job or your support system. It takes a village to have a child sometimes, but really make that village big postpartum. Sometimes people don't want their in-laws there. Have your in-laws plus all their friends around, things like that.
We had a similar conversation around this. We had a member of my membership who stopped taking her medication in the hopes of being getting pregnant. So she had stopped her medication, and talking about like just the extra support needed around that time because you don't have the medication. And so like what you were saying, like the coaching, the therapy, the extra tools, the strategies and things like that. Where one of the things I know on a personal level is I had to change from my primary doctor to a women's clinic. Do you find that common in your practice? Like, because my primary doctor was fine for certain things, but when I started talking about what what I found to be perimenopause symptoms, and she wasn't necessarily catching that those were perimenopause symptoms. And then when I switched to more of a specialized clinic, it was a game changer for me. I don't know if that's something you notice.
Yeah, I mean, I do. I think that, unfortunately, hormonal imbalance include like throughout life is not really well understood or well discussed in training. And I think that really there's a whole subsection of, perimenopause, menopause. I don't even think that all, OB-GYN training is really um, well, you know, that there is even that much that those folks are really trained on. So I think, unfortunately, when people don't understand or don't really know enough, there's a lot of kind of dismissing. And so I think that can happen with any field, whether it's the primary care or the OB-GYN. If they don't know, there's more of just, oh, that's not menopause or that's not a symptom. So I think it's really finding whether it's a female or a male, but really usually it ends up being a specialized clinic who really has the time to spend with you and really knows. It's really just kind of sitting there, really spending the time and going through all the symptoms and being willing to look at the research. Things change. Years ago, they weren't, there was a lot of concern about giving hormonal replacement. Then we learned that it wasn't as dangerous during the perimenopausal years, especially before menopause, as long as women didn't have a high risk of breast cancer or hormonal type of cancer at a young age.
I was going to ask you about your stance on that. So as long as you don't have those higher risks,
Yes.
Yeah.
Real high risk, and nothing, it's all risk versus benefit. And so, we always have to remember that at this point there is risk of, having even early menopause, and and having that decrease in estrogen, and then having the risk factors for cardiovascular disease, as well as dementia. Low estrogen has been proven to lead to dementia. So cardiovascular disease, meaning heart attack, stroke, and then also osteoporosis, which can be significant in itself. And this is all the years between, before, perimenopause can range. So that can be a year, that could be 6 months, that could be 3 years, that could be 5 years, 10 years. And so,
That's,
unfortunately,
I think, the most unbelievable thing about it is that I remember in my early 40s starting to get like hot flashes and thinking, what is going on? Like, I just couldn't figure out what was going on. And then my sister, who's older than me, was like, oh, you might want to see if you're, going into more perimenopause. And I'm doing the research and it's like up to like 10 years. And I'm like, what? It's- but it's true because I'm 52 now and I'm in menopause, and it did take about 10 years to get through perimenopause.
in full disclosure, I literally just saw my OB-GYN yesterday, and I think I may be in the beginning, but I think I could even be early perimenopause, menopause, and we were laughing, saying, "I think I could have gone through it a couple years. This could have been a couple years." And he's going through all the stuff. I'm like, I don't know. That was just me, the hot flashes, the voice that that's been me for the past 10 years. I'm like, I don't know the difference. I don't really know. I'm always stressed. I'm always waking up. I'm always this. So a lot of women, none of this is that different, especially the ones with anxiety, ADHD. I wouldn't know.
What do you notice as the ADHD? Like what ADHD symptoms tend to intensify, during this transition that you
Yes. So, definitely the working memory and so there's two different types of working memory. There's the verbal and the visual. So both, usually more the verbal, a lot of the verbal, like the fluency, just the word finding. Um, what else? The concentration, a lot of the cognitive parts, the aspects of ADHD. What else? I would say the fogginess, and that's sometimes a little bit hard to tease out what is, just part of, and that's, what is part of just, menopause and what is the ADHD. I mean, there's been studies that show that neurotypical folks will benefit from ADHD medications, specifically a type of amphetamine, Vyvanse, long acting amphetamine, and also a non-stimulant called Strattera. There has been studies to show that. So it's really kind of figuring out what's doing what. And then also some of the, ability, the distractibility. So a lot of the inattentive symptoms.
hmm So if you're in that age then where that could be a possibility, what is your recommendation? Because it is hard to know whether or not, is this just ADHD or is this worse now because I'm in this period of life? Like, how do you approach that to your doctor? Like your concerns?
You kind of want to use a two-prong approach, since y it's pretty hard to have your OB-GYN talking with your psychiatrist or or the one who's prescribing your psych medications. But so you may have to be the middle, woman, and the one who's really the case manager. But you want to at least have some sort of evidence from your gynecologist that you are in perimenopause. And it could just be, it's usually just clinical confirmation. You even, I'm thinking about it now, you may just get a quick like note from them or just confirmation and let, just verbally, and go back to your prescriber of the stimulants and let them know that you think you're in perimenopause, you are in perimenopause, and you can They may be fully aware that at this point it would be helpful to increase your meds, the doses, or to add to, or to consider adjustments at this point. Um, and then I would first suggest doing it that way. And if they're maybe not too stimulating, or maybe adding um, extra, if you're not on PRNs, meaning extra short acting doses throughout the day, later in the day, depending on where you're having trouble, or sometimes adding something a little bit more activating that can help for some of the fogginess along with the stimulants, things like that. And then after some months of trying that, trial and error, then then going backwards and talking with the gynecologist and seeing if at this point, possibly adding on the hormone replacement therapy would also be helpful. You could do it the other way, but when you're already diagnosed, it would be useful to start with, and there's no evidence for this, but it would be useful to start with the stimulants since we know they're so quick acting. You can know pretty quickly if they're effective. And I do that with many types of comorbidities with ADHD because unless someone is going to destabilize, I'll know if I increase that Adderall or Vyvanse, I'll know within a couple days to a week if I'm going to get a better response.
So I'm going to ping pong back to the hormone replacement therapy. Can you explain more about what this is and how it works, and what are the effects? Like, why is it a benefit, or why could it be a benefit to someone?
And then how it specifically interacts with the meds, with your strategy around meds. That's fascinating to me.
Yeah, I don't personally prescribe it because I'm not a gynecologist, but basically what you're doing is there's different ways to go about it. You're either going to be giving a replacement of estrogen and progesterone, or you're just going to be it's less likely to just be doing estrogen itself. And usually it is an oral form of the estrogen and progesterone. And there are times. So basically you're giving back what your body has, you're giving back during that perimenopausal time. You are increasing that estrogen that you have lost. So you're bringing it back to somewhat of a normal level for that time period. And it's important that you're not doing it in the postmenopausal or when you're in menopause, since that's when your body is supposed to be at a decreased level. It's not supposed to be at a decreased level during this time.
So once you hit menopause, then do you stop taking the hormone replacement therapy? Okay, good to know.
Yes. So really, and unfortunately, the whole idea behind this is we don't know what is normal for each person. We don't know where we began. Right? We weren't doing levels their whole life. But what we do know is we go by symptoms. The other thing is some people, if they are nervous about hormone replacement, or they have a family history of breast cancer or ovarian, uterine, hormonally dependent cancers, they can do even topical type of estrogen, so that can help with some of the vaginal dryness, some of the urinary symptoms, things like that. Also changing some natural types of over-the-counter vitamins and supplements can be really helpful. Going to not a prescriber, but someone who really knows that type of stuff really can really provide a regimen that is helpful. Also, what else? And also making sure that testosterone is not left out. Testosterone pellets, it's really looking at, and that's why you really want to see someone who really knows what they're doing. Unfortunately, just like everything else, there's now these clinics popping up online, like get your hormones within like 20 minutes, everything you need. monthly. But, figuring out what symptom is what, decreased libido could mean this hormone is lowered, but testosterone may need to be replenished. And you could do that with adding that into the hormone replacement as well.
I think it really does make a difference on the doctor, because the clinic I go to, we do a lab every 3 months. I get my blood checked and she checks the lab. She looks at all the hormones. She looks at everything. I'm on different supplements that she's recommended. And I can tell you, I feel like night and day. I mean, compared to when I first went in with all of these symptoms, brain fog, memory, mood, edginess, crankiness, all of these things that weren't me, right? That weren't me on a normal, day-to-day life, weight gain, all of that stuff. And it really does make a difference. So how do we empower people when they're feeling so horrible what are those first steps of, okay, I can feel better? Is it that conversation with the doctor? Is it research? Is it like, what is it?
I think it is the conversation with the doctor. Really, I think possibly even bringing some information, if they can, that's just general information. Sometimes even if they can email or message, just so it's put in their, can you still hear me? Yeah. Okay. Just so it's put in their message box, and they don't feel like, they know that just saying something like, hey, I wanted to talk to so and so during my appointment. So it's not out of the blue, just making sure there's enough time. I've been struggling with this. It's always nice to know what someone's going to bring up, making sure that you set enough time. And also, um, coming up with ways that you can basically be referred in the right manner, and also know that you may not leave that one appointment with the information that you want, but that's the first step that you've advocated.
That you've
And
advocated.
yes.
for
And
yourself. And
so
you've said something like something not right.
exactly. And
Yeah.
so kind of almost unfortunately lowering your expectation, but knowing you're that much closer to getting the treatment that you need.
So it starts with that conversation, and that is a process. I mean, from my own experience, that it was a process of a lot of trial and error. And again, taking my blood again 3 months later. Where are we at now? What are some practical strategies that you tell your clients who have ADHD and who are going through these hormonal changes that can help, that aren't necessarily around supplements and the hormonal replacements and things like that?
So, really, it sounds so simple, but getting adequate sleep, the sleep wake cycle is so important. People don't realize how important, but really, most of these disorders, including, it's not a disorder, but, you know, perimenopause is related to, it can be somewhat, if we think of it as, PMDD, and we think of it, the depression component, or ADHD, a lot of those disorders had this sleep wake dysfunction where the natural melatonin, which is another type of hormone, is released at the wrong time. And so, in order to reset the system, we have to really make it not just adequate sleep, but I think what women can do is try to go to sleep the same time every day, and try to wake up the same time every day, even on the weekends. And that's really important. And also making sure that they have a varied diet. And really, there was this thought that you really couldn't eat the, soy and all of those estrogen containing products. But I think if you do it in moderation, you don't have this, really high a family history of the hormone dependent cancers, then just making sure that you're having enough products that have phytoestrogen, and just soy, beans, things like that. Also, um, what else? Exercise, cardiovascular, weight training, making sure that you're getting enough of that. And then really connection, really socializing, having support. I can't really emphasize that enough. Also, this is just like every other type of mental health issue. And again, this is not a mental health issue, but I'm just going to compare it in that way. Opening up the dialogue, being open and transparent. The less that we stigmatize this, the more we have conversations, I think the more it's going to lessen the shame and the guilt surrounding it. And unfortunately, this is not discussed enough. Just like, no one, we're not able to even have time off from work. No one would even think about saying, hey, I need a menopause day, right?
Mm-hmm, mm-hmm,
Yeah.
mm-hmm.
I mean,
Although I think we should.
Hearing you say it seems so absurd that we don't. Listening to you guys talk about this, I'm like, why do you go to work for 10 straight years? Like, just take the decade off. It sucks. Find a boat and go relax. You deserve it.
I mean, I think we're ready to start menopause day.
Yeah.
Yeah.
I know, because somebody's got to start it. Hey, a quick question. You mentioned cardiovascular. We know the benefits of health, but I read a bit that struck me about how important strength training specifically is during this decade. Like, if you're not lifting heavy things on a regular basis, you could be doing so at your detriment. Can you just, you just said strength training is important, but I'd love to know why, because I think that's probably a thing.
Yeah. You really want to really make sure that you're getting enough calcium. And then you want to make sure that you are weight training because you're having less estrogen, and less estrogen means that you are basically not having the same muscle and bone, and you could really, depending on your family history and where you are with your bone density, you want to be getting DEXA scans and making sure that you don't already have a propensity to osteopenia, which is the beginning of kind of the early stages of what's called osteoporosis, which is something that women in their later stages, especially women who go through this menopause earlier, can develop. So I think almost, perimenopausal, especially if you're 10 years of it, you really want to be really lifting and keeping yourself strong enough that doesn't become an issue, because once it does, it's really hard to change it. Although there are newer meds out there that are pretty really very different than we had years ago. However, it's once the damage is done, it's done.
Yeah, I just want to make sure we highlight that, because I think I'll speak just locally. The women who are going through this in my circle, like their expression of fitness doesn't include lifting heavy things and actual strength training. It's like I get on the bike and I do my cardio, or I do the things I've always done. But everything I'm hearing is, if you're not doing that and including actually getting stronger, you're doing a real disservice to your bones and your skeletal structure. Yeah.
So important.
Okay.
It just reminds me, though, like I can't believe that I have this image of myself, because I just, we never really picture ourselves older, but I have this like image of myself doing mall walking, with gray hair, with my
that's
little
that's what you're
weights.
Aspiring to now?
Yes, like with my 5-pound weights, and I'm going to be out there and I'm going to be walking with my weights.
I love it, right? I remember my grandma doing that in the hallway.
Yeah.
Yes, yeah, because it is so important.
But
this
see, you can lift more than that, Nikki. 5-pound weight. Yeah. If you're doing 5 pounds, you should be lifting a lot more than that by then, right? You should be bulking up.
I should be
shredding.
25
Just start shredding.
pounds. Yeah.
I think you could start competing in bodybuilding competitions. Let's just say
at 70 years old,
we have a path.
That's where I'm headed. Yeah.
Yep. Oh, Dr. Dara, you're amazing. Thank you so much for coming on and talking to us about this and helping people. We sure appreciate you. I've got links to your LinkedIn and to your website. You want to tell us a little bit more about what you have going on at your practice?
So I, basically see adults and adolescents with adult ADHD and then adolescents and all their comorbidities, which, ADHD does not exist in a vacuum, as well as women with PMDD and postpartum and perimenopause and menopause. And I just love what I do. We're expanding and have another prescriber, nurse practitioner. And right now I am working on writing a book. And I am just, have 2 small kiddos and enjoying life, trying to keep up with everything.
Well, thank you so much for doing all that and making time to come talk to us today.
Thank you so much.
You're a treasure. Thank you so much for doing that. Thank you, everybody, for downloading and listening to this show. Thanks for your time and your attention. Don't forget, if you have something to contribute to the conversation, we're heading over to the Show Talk channel in our Discord server, and you can join us right there by becoming a supporting member at the deluxe level or better. On behalf of Nikki Kinzer and Dr. Dara, I'm Pete Wright. We'll catch you next time right here on Taking Control, the ADHD Podcast.